Prof Colleen Lau, I think is, there she is, sorry. Thank you, to look at one of the tools we've developed, and it's really on the table, and we're getting a lot of interest in how to use it and to know that it's there and to change people's view that maybe they should take a vaccine. So, Colleen, thank you.
Thanks very much, Rod, and thank you for the invitation to speak here today. So I'm going to talk about CoRiCal, which stands for the COVID-19 calculator. Just get this moving. Which is hosted on the Immunisation Coalition's website, and also a bit about some of the other clinical decision support tools for vaccines that we've been working on. So I'm based at the UQ Centre for Clinical Research, and the CoRiCal project is a collaboration between multiple universities. John Litt, who's sitting in the front here, I'm not sure if Kirsty Short is here. John and Kirsty and I are the three leading chairs of the CoRiCal project. So when we're talking about risk-benefit analysis of vaccines, there are many different considerations. So firstly, when we think about risk, predominantly we're thinking about adverse events following immunisation. And so this depends on all kinds of demographic factors, as well as things related to the vaccine, which dose it is, route of administration, and other things. And then for the benefits, we're really thinking about the illness and deaths that are prevented from being vaccinated. So this also depends on demographics, but also on the probability of infection. And if you are infected, what are your chances of getting severe illness or dying? And also things like vaccine effectiveness, the duration of protection, and from a public health perspective, sometimes herd immunity also comes into consideration. And there are some situations where this risk-benefit analysis is especially challenging. So with new vaccines, where we're not very sure about adverse events, vaccine effectiveness, and when things are changing very quickly, for example, during COVID, this was quite challenging. And the changing epidemiology as well. So your chances of getting infected depends on what's going on in the community. So again, COVID, we had zero COVID sometimes, we had lots of cases sometimes, big outbreaks sometimes. So your chances of getting infected, and therefore your benefit from vaccination, also changes. Then special groups like children, elderly, immunosuppressed, pregnant women, travellers. And the cost of vaccines also comes into consideration sometimes. So things that are recommended but unfunded, and also for travel vaccines, which are mostly unfunded, that's often a consideration during travel medicine consultations. And if we're talking about quantitative risk-benefit analysis, we need data. And access to data can be quite challenging. So for example, during COVID, getting access to clinical data, surveillance data was particularly challenging when we were trying to put together this CoRiCal tool. So for clinicians, public health decision makers, trying to weigh up these risks versus benefits can be really difficult, particularly during a consultation where you want to come up with an answer fairly quickly. And there are quantitative risk-benefit analyses and also qualitative ones. And today I'll talk mostly about the quantitative analyses, because that's what the CoRiCal tool is based on. So a couple of weeks ago, there was a publication on a systematic review of quantitative risk-benefit analyses for COVID-19 vaccines. So they reviewed papers up till April 2023, and they found 37 papers worldwide, and 6 of these were from Australia, which is great. And the authors classified these analyses into simple or complex models. So simple models were mostly things like descriptive statistics that did not take into account changes in transmission or differences between subgroups, and then complex models. So 3 out of these 4 complex models were what we call Bayesian network models, and these 3 were the models that underpinned the CoRiCal decision support tools. So what are Bayesian network models? These are based on the Bayes theorem of conditional probabilities. And Thomas Bayes was a statistician and philosopher who lived in the 1700s. So these are not new concepts, but once we get to models that involve lots of different variables and lots of different quantitative relationships between these variables, it becomes computationally very demanding. So in terms of computer power, these sorts of models have only become popular in more recent years, and they're used a lot in complex systems like ecology, economics, engineering, artificial intelligence, but relatively underused in medicine and public health. So here's an example of a relatively simple conditional probability problem. So say we have a population, half male, half female, 100% vaccinated just to keep it simple, and vaccine effectiveness of 90%, so it works pretty well. And if you get infected, you have a case fatality of 10% of your male and 20% of your female. So the question is, if 100% of the population is exposed and have a chance of being infected, what percentage will die? I'll give you a moment to have a think about that. Anybody want to propose an answer? Okay, so who thinks it's 0.05%? Nobody. Who thinks it's 1.5%? Okay, we've got a few hands. Who thinks it's 5%? Nobody. Okay, so we have a few people who can actually do these things very quickly in their heads, but most people can't. And once you make it more complex, it becomes more and more and more difficult. So this is what a Bayesian network looked like, a very, very simple Bayesian network where we just have three variables, one about vaccine effectiveness, one on sex, and one on the probability of dying from COVID. So the answer to this question is 1.5%. For those who got that right, congratulations. But most people really cannot calculate this once it becomes more complex. So this model is underpinned by what we call a conditional probability table, that blue table underneath, where we put in those numbers, those assumptions that we had. So on the right-hand side is an example of how you can use this model to do scenario analysis. So we're saying here that the vaccine didn't work, which means people got infected. We're just looking at males, and the chances of dying in that subpopulation was 20%, which essentially is consistent with our assumptions. Okay, so once we get more complex, I'm sure that even those people who got the 1.5% correct will not be able to do this in their heads. So this is a model that underpinned our Pfizer COVID-19 CoRiCal risk calculator, focusing mostly on the likelihood of myocarditis under various scenarios. So we can put in different inputs related to vaccine doses, age distribution or age of that person, or distribution if we're doing a public health level analysis, level of community transmission, changing vaccine effectiveness over time because of changes in variants, and looking at various outputs of interest. So myocarditis was the outcome of most interest for this model, but there's also background myocarditis in the community not related to the vaccine, so we need to take that into account as well. So the advantages of these sorts of models is that we can incorporate data from multiple sources. So the CoRiCal tools, unfortunately, we did not have access to giant data sets where we can learn these probabilities, but we can also use a different approach where we bring in data from multiple sources and put it into those conditional probability tables. So the interface with these models are fairly visual, which means we can explain it to people more easily, and it's easier generally for non-modelers to understand this compared to some of the other types of models, and we can use it for scenario analysis. And we can also update evidence relatively easily as things become available. So the CoRiCal Risk Calculator project, this is hosted on the Immunisation Coalition website, freely available to anybody, to clinicians and patients. So this was developed by a team of multidisciplinary researchers from UQ, Flinders, University of Sydney and QUT. So we had clinicians, modelers, epidemiologists and statisticians and digital science people. and it's independent of government and pharma. And essentially, they're quantitative risk-benefit calculators based on these Bayesian networks. Now, most people would not really know how to use a Bayesian network, so what we did was we built a digital workflow that enabled the outputs of the models to be accessible by anybody through a web-based interface. So I'll show you some examples in a minute. Also, there are some static risk charts, some explanatory videos, and all of the models were built to be relevant to the Australian context. So we've built various calculators over the last, I think, almost 3 years, John, something like that. And for the first 2.5 years, I never actually met John in person. So a lot of this was done online during, a lot of the lockdown times. And we pivoted to whatever, the questions of the time were. And some of these models now are not really relevant anymore, like the AstraZeneca model. But the latest model that we have is on long COVID. So I'll talk a little bit about the long COVID model. This is work led by Jane Sinclair, who is Kirsty Short's PhD student, and I'm also one of her co-supervisors. And she's done a lot of work on putting this together. So essentially, the model is built to estimate the probability of long COVID at 6 months post-infection using this Bayesian network approach. So these probabilities are based on age, sex, comorbidities, number of infections, the number and timing of vaccines and boosters, and also the use of antivirals in the first week of illness. Now, we chose these as the inputs because these are the things that we know will influence your probability of getting long COVID, and also that we have some data on them from various sources. Then the sources of information or data came from published literature, surveillance data, government reports, and various other places. Also expert opinion. So this is what it looks like when you go to the CoRiCal website, and you probably can't read all of that in great detail, but essentially this person has put in her details. She's a 32-year-old female with anxiety, depression, and obesity. She's had 2 or more COVID infections, and she has had 2 boosters, 2 or more boosters, so at least 4 doses of the vaccine, and the last dose was more than 6 months ago. So you can enter this depending on your own or your patient's situation, and you get an output of various things, looking something like this on the website. So you can choose the outputs to be shown as risk as a chance, so for example 1 in 1,000 chance, or risk per million, such as 1,000 per million. And if we look more closely at each of these charts, this one is about if she gets COVID-19, what's her chance of going to hospital? So the dark bar refers to her, so that says a 1 in 76 chance. And then there are some other bars that gives her some indication of how her chances would be different if she had different numbers of vaccines, different numbers of infections, or if she took antivirals. Okay, so it just gives you some different scenarios of, if you did this, what would your chance be? How would that be quantitatively different? This one's her chances of going to ICU, which is much less, 1 in 23,000. Again, some other comparisons based on the different inputs that you might be able to put in there. So the other outputs on this model are related to either your chances of having at least 1 long COVID symptom at 6 months, or having system-specific long COVID symptoms, such as brain-related symptoms, cardiovascular symptoms, GI symptoms, etc. So this one's related to brain-related long COVID symptoms. So again, the dark bar is her, and then the other examples of what might happen if she was not vaccinated. And so these estimates were based on data that were available at the time. And this tool is quite a few months old now, and people must say, hey, there's new data. And the advantage of these sorts of models is that we can actually update those numbers. So if people don't agree with any of these estimates, we'd love to hear from you about where newer and better data are available, and we can update the models. So a similar one about having metabolic long COVID symptoms, and at the bottom it's just a summary of all the other outputs that are available on the website. So we also have some static risk charts. So there are some people who don't really like interactive tools. This is very similar to the cardiovascular risk charts, which all clinicians will be familiar with. And it just shows the probability of long COVID per million based on sex, number of infections, and number and timing of vaccines. So this is not on the CoRiCal website yet, but it's on the long COVID preprint that's available. There are some videos which Carissa Bonner from University of Sydney has put together, and she has expertise in risk communication, health literacy, shared decision making, and evaluation of tools. So here down the bottom you can see the video explaining the benefits of vaccination, antivirals, and also the impact of multiple infections on long COVID. While we're talking about long COVID, there are also some long COVID podcasts that John Litt has facilitated, and they're available for free through the Health Ed website. So one of them with Brendan Crabb talking about lots of different aspects of long COVID, including the current research and evidence, and then two with Stephen Foe, part one related to epidemiology, risk factors, etc., and part two related to treatment. So John is the best person to ask about these, but they are really informative to listen to. So apart from clinical decision making, these models can also be used to support public health decision making. So rather than generating model outputs at an individual level, we can also generate them at a population level. So this is an example of what we did with the Pfizer COVID vaccine, looking at myocarditis, a scenario of population vaccination coverage, and showing the number of symptomatic COVID infections we can prevent, number of deaths by age group, and also myocarditis, which is the risk or the adverse event from the vaccine based on age and sex. Okay, so a few publications that people can have a look at if they're interested in the approach or the results. And just very quickly, I just want to also show that we've used a similar approach for travel vaccines. So I'm a travel medicine doctor by background, and advising travellers on Japanese encephalitis vaccination is quite challenging because it's widespread in Asia, but very few travellers actually get infected, something like 1 in a million. But if you do get infected, you have a 20 to 30% case fatality rate. And even if you survive, there are some pretty nasty complications. And it's an expensive vaccine. So the live vaccine ImaJeff is about $300 a dose. So using a similar approach, a Bayesian network approach, we built a model which has 3 submodels, one related to the risk of infection, one related to adverse events, and one related to clinical illness. And we have an interactive tool similar to the CoRiCal tool, where you can put in the inputs related to the country of travel, urban versus rural destinations, trip duration, the month because risk is seasonal, age, sex, comorbidities, mosquito avoidance, and also which vaccine you've had, or maybe you've had no vaccine at all. And you get outputs looking something like this. So the orange bars are for people who are not vaccinated versus the green bars where they were vaccinated, and the outputs are related to meningitis, encephalitis, hospitalization, death, complications, and also blue at the bottom are the adverse events from the vaccine. So these are, again, freely available to anybody, and if you want to have a read about it, it's published in the Journal of Travel Medicine. And just the very last thing, I know running out of time and it's lunchtime, another challenge we have in travel medicine is giving multiple vaccines on the same day. Now, I know we do that with routine childhood immunizations, but with those, everyone gets the same thing and we have heaps of data about safety. But in travel, we give people a range of different combinations of vaccines and we don't have a lot of data on those. So we've looked at this using machine learning models, with smart vax data. And here's an example where if you just have the Imager vaccine by itself, you have a 1 in 700 chance of having some sort of adverse event. But if you give it together with hepatitis A or B vaccine, it increases substantially. So this tool allows you to look at different combinations of vaccines, and we're doing something similar with the shingles vaccine. So a few other things that we're working on: yellow fever vaccine for travellers, shingles vaccine. We're just starting to think about doing this for RSV, and also concomitant administration of multiple vaccines, and also assessing the usefulness and the impact of these tools for actual decision making. So thanks very much for your attention, and lots of people have been involved in this project, both the CoRiCal and the Japanese encephalitis tools, and happy to take any questions, but I think it's lunchtime.
Panel. So, yeah. Thank you.